It's nice to hear so much happiness in the room, and I hope you leave feeling that way. So welcome to the State of the Department Grand Rounds this morning. I'm Charles Woods. I think most of you know who I am, and we're not going to go into any other introduction at this point. I will tell you that the people in the front row are safe because this podium doesn't move into the crowd. So... Okay, so I'm going to give you a quick overview of what I'm going to cover. So we're going to talk about our missions, review those briefly. Who are we? Where are we today as a department? What are some challenges we face? What are some opportunities we have? And then we'll move briefly into the teaching and research missions and then some leadership bandwidth things to discuss around our missions and such as well. I want to thank all of my staff and many of you who supplied data for this. This is not something that occurs by me alone. There's a lot of help involved. Now, before I go further, I'm going to I don't have to introduce Jerry Rabelais, who has a couple of words he's going to say.
Thanks, Charles. Good morning. Well, as you know, 1 year ago, the board of the University of Louisville Physicians, our practice plan, asked me to step in as the acting CEO while Dr. Postal was elevated to the Vice President for Health Affairs role. And so I stepped into that role in a part-time capacity, continuing to serve as chairman of Pediatrics and trying to serve Dr. Gansel's needs as an associate dean for faculty development. It was supposed to last 3 to 6 months. You know well what happened at levels above us. When it got to October, I pointed out to Dr. Postal that October is longer than 3 to 6 months, that we needed to talk about what the longer-term plan was, and you know since October how much has changed. And so I want you to know that as of December 1st, I formally notified the dean that I would not be returning as chairman of the Department of Pediatrics, that she should appoint Dr. Woods as the acting chair, and that I would continue to serve in a near full-time capacity at ULP. Let me assure you there is much to do. It is not a part-time job, and what became clear throughout 2016 was that I had to commit so much more time there that I simply couldn't do justice to the department, the ULP, and to the dean's office to try and do all three. And so effective 2 months ago, I have officially stepped down as chair of the Department of Pediatrics and will not be returning to this role. Let me tell you a couple things. First, the 12 and a half years I served as chair were some of the most rewarding, satisfying, and challenging times in my career. I was humbled and privileged to be able to serve as your chair and to have the opportunity to do that following Dr. Andrews, then Dr. Cook, myself. We've only had 3 chairs in the past 50 years in this Department of Pediatrics, and a stability that I think has contributed to the success of this great department. So thank you for the opportunity that you provided to me to be able to serve for those 12 and a half years as your chair. The second thing I want to tell you is that you're being left in very good hands. For the past 2 years, Dr. Woods and I have literally worked in adjacent offices with the issues and problems and issues that have come forward in this department. For 6 months, he served as your acting chair while I was away on sabbatical. And then for the subsequent 18 months, he has had a graded increase in things I give him. He didn't know how to say no. And so I just kept pouring toward him, and he took it on. And I ramped up in another world, he ramped up in this world. And so much like a relay race where you have to hand over a baton, and there's a running period where the lead runner's leading back with the baton and the other runner's coming up. Today that baton gets handed over, and it's Dr. Woods' race from this point forward. So Dr. Woods, thank you for all you've done for me. For this past several years that we've worked closely together, especially the past 2 years. Dr. Gansel, thank you for allowing me to make this transition and allow this smooth progression of transition and leadership for the Department of Pediatrics. Charles, congratulations.
So thank you. And first, I am interim. So that is the official title, just to clarify. Jerry, thank you for all you've done for all of us under much duress, many days in these over the past decade, at least the time I've been here. And I know this is one of your favorite pictures, and I think it is something that should symbolize a lot for us, as Jerry has said, the sacred space between the physician and the patient. And I'd never want us to lose sight of that. And I think this becomes a staple to me for our future State of the Department addresses as something we should not forget. All right. Quick review of our missions, just to remind you, what is it that we show up every day to do, or why do we do it? So I start with the School of Medicine and ULP to improve the health of our patients and communities through excellence in leadership and education, clinical care, research, and community engagement. Deliver patient-centered care with compassion and excellence. We work in a hospital system as well. Norton Healthcare's purpose, provide quality health care to all we serve in a manner that responds to the needs of our communities and honors our faith heritage. And in the Children's Hospital, adding to that, every age, every stage, every step of the way. And then as a department, our missions are in the context and collaboration with those missions. So we exist to meet the health-related needs of children. I've added a couple of words in. And then we serve that mission really actually in 4 ways: through clinical care, medical education, pediatric research, and advocacy and community engagement. And these are also parts of the strategic plan of the university. And there's one more step I think we have to think about, and that is operationalizing this a bit. We will provide excellent care for every child, adolescent, and adult who comes to us, regardless of their personal identity, beliefs, or family structure, with respect and within an environment each can perceive as safe. And we have a lot of diversity in our faculty. We have a lot of diversity in the work we do, who we are. We have diversity in our patient populations and those who come to see us. So this is our goal as we move forward. Now, we talk a lot about vision and mission and values, and then we have strategy. And it's great to say all of this, but it doesn't matter if we don't get it into day-to-day reality. And that involves getting into the weeds and moving forward. And so that is a collective effort that we all have to think about and remember together. This is our work. All right, so who are we as a department today? We can start out with some basic questions. You can answer that in a number of different ways. We're faculty members and staff of a School of Medicine. We're a clinical workforce of Norton Children's Hospital. We're subspecialty and academic pediatric healthcare providers for children in the Louisville area and much of the Commonwealth. We're divisions and teams that work together. We're individuals who strive for excellence, and we're members of our community. All of those things describe who we are. Now, we've grown in number in terms of faculty. If you look at the slide back in the late 80s, we were in the low 30s. We have plateaued to just under 200. We're at 192 right now. And so that's a phenomenal growth in that period of time. In terms of how our department fits, I thought it was useful to review our structure. We are individual faculty members. We work in divisions, sometimes more than one. We come together as a department with a central administration. And then we are then within the School of Medicine, the Health Sciences campus, and the University of Louisville Physicians practice plan. And then all of that underneath the board of directors. So we have a lot of autonomy, but we are in a structure. So I have 3 reports and that we need to work within, again, all of these missions. Now, another thing to put into context is that the pediatrics world is bigger than our department, and it's actually bigger than the School of Medicine. So if you look at the school, if you line up all the departments from the adult side, and then you line up pediatrics, we are sort of an analog of 4 adult departments in the School of Medicine. But then we have colleagues, pediatric neurology, pediatric surgeons, pediatric ENT, pediatric neurosurgery, pediatric radiology, pediatric anesthesiology, all of these. Some are Norton employed, some are Norton contracted, some are university. But we're really all part of that together as a group that provides comprehensive health care to children. And we need everyone on every part of that. I just thought it's useful to put that into perspective. And the pediatric, our department and the other pediatric components of the School of Medicine are about 40% of the School of Medicine. So it's a sizable part that we are and contribute. Now I'm going to review the next slides fairly quickly. This is our faculty by divisions. Now, if you read fast, you might see some people listed in more than one location. But we have a lot of divisions and units. So you can see these: adolescent, allergy immunology, cardiology, child and adolescent psychiatry, psychology, critical care, emergency medicine, endocrinology, forensic medicine, gastroenterology, general pediatrics, hematology, oncology, hospital medicine, infectious disease, international pediatrics, medical education, neonatology and neonatal follow-up, nephrology, pulmonology, rheumatology, sleep medicine, the Weisskopf Center, which is child and behavioral developmental pediatrics, and genetics. In terms of research, we have 4 units: the Child and Adolescent Health Research Design and Support Unit, Kosair Charities Pediatric Clinical Research Unit, Pediatric Research Institute, and the Pediatric Clinical Trials Unit. But we're a lot more than a faculty. We have about 400 staff who work with us and support us in many important ways. We have 63 nurse practitioners and physician assistants. We think we got everybody. We have a central administration in all of these areas: accounting and finance, administrative support, clinical operations, faculty affairs, information technology, medical education, and special projects. And I'll just say, I'll single out 2. I can't give everybody's name, and I promise you I'm going to miss some people. It's not intentional. But I do want to say a thanks to Ruby Keith and to Andres Arias, because I couldn't do, and Jerry couldn't have been doing, what has happened, certainly in the last year, but over time, without their support, certainly for Ruby over a long period of time. We have a lot of support staff. This is just some of them: the academic support leaders, clinical practice managers, fellowship coordinators. And some of you may be in here and you do other important things. I don't have enough slides. But there are a lot of you, and everything that each one of you does matters and is important to serving the missions that we have. But it's a great scope of people and work. Over the last decade, I will tell you, I think our national presence and reputation has really continued to grow significantly. This has to do with basically all of our missions, both clinical, teaching, and research. There are many of you involved with AAP leadership and other national organizations at the state level and nationally. A good number of you are on editorial boards and have other editorial roles. Some of you are on NIH study sections and review panels. A lot of you have national meeting presentations. So there's a lot going on. There's a lot that has moved forward, and it's been a privilege to see that in the time I've been here now, a little over 10 years. And we have a lot of partners. I think I've listed all the schools except the School of Music, and I should have put them on there too, because in the new building and some other things, we really need musicians, and we need theater, and we need art. So everything, we are in partnership across the spectrum. But we have direct relationships with people in many of these schools with various projects that are going on. Now, in terms of our institutional partners, the School of Medicine and Norton Children's are our primary key partners. We work together hand in hand. Now, there are more under here that also we have relationships with, and you can see in some ways a continuum of child health and advocacy. We have a nursery at ULH. We provide health care at Maryhurst. We provide services at Home of the Innocents, and I will just say what an incredible community resource, Home of the Innocents. It is a rare thing to have in this country even. And what they have done, and they are for children, they are a wonderful partner and resource. I can't say enough. Similarly, Heiser Hearing is a world-class, world-renowned institute helping children with deafness or hearing impairment. Kentucky Youth Advocates, they advocate, but we do too, and we're increasingly partnering. Again, what an amazing resource. We have relationships with UK, and I think we need to actually look at ways to increase those over time as we share this common mission to the children of the Commonwealth. Passport Health Plan, we have relationships with them a little more closely than the other MCOs because of long-term historical relationships and their share of this market. And we have relationships with several regional hospitals through our neonatal outreach. We have Philanthropic Partners, and we need all of them. We are grateful to Kosair Charities for their support over the years, to Crusade for Children. Children's Hospital Foundation is a major resource for both the hospital and its success, which helps us, and then some of that comes across to us. The University of Louisville Development Office, and I'm going to talk more about that in just a second, but all of these very important. And then Raise Red, and we have a Departmental Pediatric Advisory Council, and there are actually more. Now, just a quick message about Raise Red. This is a dance-a-thon that the U of L undergraduate students do. It is next weekend. It starts Friday night. The community celebration is in the morning for those of us who won't be there all night. They had a little prom event for some of the HEMONC patients at Gilda's Place a couple of weeks ago. And then this week, I think you can read Papa John's has given a check to Raise Red for about $31,000. So it's a really great event supporting our hematology oncology division. In terms of development, Ryan Floth will arrive Monday as Executive Director of Development for the Health Sciences Campus focused on pediatrics. He's a U of L alum. He's coming to us from Cincinnati Children's, where he has been Director of Corporate and Foundation Relations. This is very important. He's going to have an office in the KCPC on the second floor, so he'll be visible and getting to know us. Sarah Hugenberg, and Sarah, raise your hand. Back in the back is our development officer for pediatrics. She will work with Ryan, and together they are evidence of the priority and emphasis that the university is placing on the department in terms of fundraising. So some roles we can play, just so you know, there's a Grateful Patient Program. If you have a patient who might be interested, let Sarah know. And in giving back, let Sarah know about that. There's the Cards All In program. This is university-wide, but this is something where we can donate to ourselves, and healthy organizations do that. And our rate overall is about 15% as a school or as a university. We need to get that higher. So just we'll encourage you to consider that. There's a plan for fundraising for the new pediatric medical office building. Some of you may be engaged by the development office to help with various parts of that over time. And there's Sarah's contact information. Now, just for a little bit of peaceful reflection, this is Spirit Lake in Lake Moline in Alberta, Canada. It's frozen over right now, probably, but in the summer, very beautiful. All right, so what are some challenges we face? And I'm going to start off with just general health of our populations and then move into financial. And through this, at these little breaks, I showed you all of our divisions. There's a little small patient vignette, thumbnail of a patient. OUD is opioid use disorder. VSD is ventricular septal defect. NAS is neonatal abstinence syndrome and abnormal newborn screen. And so a child like this could encounter all of these divisions. And you can see there's CT surgery, so it's not just in the pediatrics department. And as you go through, you'll see it's also Norton employed subspecialists as well, who are all working together. All right, Kentucky child health issues. Obesity, child abuse, poverty, foster care, one of the highest rates in the country. Overprescribing of antimicrobials and psychotropics. The opioid use disorder epidemic. This is probably our greatest crisis. Our neonatologists have taken care of over 1,100 such babies in the last 4.5 years. Perinatal hepatitis C. A lot of this is needle use. Hepatitis C, not so much HIV yet, but still there. Right now, 1 in 63 live births in the state of Kentucky is estimated to be to a mother with hepatitis C. Our PEDS ID group saw 25 such babies in 2012. They saw 180 in 2016. Now, most of them don't have it. It's only about a 3 to 5% transmission rate, but we have to evaluate them. So this is a crisis. You see the ACEs here. So in pediatrics, we define an ACE as an adverse childhood experience. And you don't want 4 of them. So you don't want any. But many of our children have 3, 4, 5. And ACEs beget ACEs. Many of the people who have issues with opioids at this point had plenty of ACEs in their childhood. And that relates to where they are now. Their children have ACEs. If you just want to know, this is recent data. On Sunday, there was a CNN online headline, 52 calls in 32 hours for overdoses in the city of Louisville. And 2 days later, it was 151 in 4 days. So the mayors are trying to respond with more police hires. They run out of naloxone and have to go back to get it because they've used up the supply they went out with. So this is, unfortunately, a new reality. We hope we can find a way to curb this. Now, back to Kentucky Youth Advocates, and one of the ways we approach some of this, there is something called a blueprint for Kentucky's children that they have developed. They're very active with many groups locally and statewide and with the legislature in Frankfurt. They have a number of policy priorities, a lot of which are not directly healthcare related, but ultimately are health related in terms of outcomes. And you can see that their goals are thriving communities, strong families, successful kids. So they are natural partners for the work we do, and we are natural partners for them. Lastly in this, I don't know how many of you have read this book. I would recommend it to every one of you. It's not a long-term, it doesn't take a long time, but this is the story of J.D. Vance is basically his autobiography of growing up in eastern Kentucky and actually mostly eastern Ohio. So we're not alone in this, but his family was in eastern Kentucky. And it's a story of ACEs. Now, somehow, J.D. made it to Yale Law School. But he is the exception, not the rule. And we need to find ways to make him the rule and not the exception. Okay. Peyto Lake in Alberta, stunning when you first walk over this little trail and see it. Should be on your bucket list. Okay. Other challenges we face. Here a little vignette showed you the newborn, older sibling, asthma, physical abuse with a fracture, PICU admit from the ED, sinusitis. Again, you can see a list of subspecialists who might be involved in this child's care. All right. Predicting and mitigating storms. This was Hermine back in the fall, brushed the coast. There was one track that was right, but it's hard to always know. But we do the best we can to look ahead and try to mitigate what may be coming our direction. All right, something that's coming our direction. It will be in the adult world before the pediatrics world, but it's not going to be far behind, and that's alternative payment methods. This was established by the MACRA Act of 2015. It is a bipartisan view. It has got a lot of support at many levels. This is actually distinct from the Affordable Care Act, so it will not go away. And you can argue it probably shouldn't go away, but it's going to push us from a fee-for-service world into a population health maintenance world, where the goal is to keep people well rather than treating their illness. Now, there's also been a lot of talk the last decade about value in healthcare, and what is value? It is the perceived quality of the care over the cost. Now, this sometimes is not a strict mathematical formula, but it gives you the concepts. Now, we'll tell you expenses on the outpatient side of healthcare delivery, and actually even on the inpatient side at times, often exceed what we are reimbursed. And quality, a lot of times, requires more people than less. I'm not sure that we can always achieve excellent care with less cost. Sometimes you might break even. So subsidies have to come from somewhere for us to be able to provide excellent care, high quality care. And that works best, honestly, in integrated healthcare systems. So I thought I'd give you examples of the way different pediatric systems are structured in the United States. So you have full integration where the Children's Hospital and the pediatric workforce are really the same organization. That can be with a freestanding Children's Hospital or where the Children's Hospital is part of an adult group or adult system. Examples of that are Cincinnati, Vanderbilt, Riley up in Indianapolis, Pittsburgh, and UK. Now, there are a lot of other examples where there's an affiliation agreement. And again, it can be freestanding or part of an adult system. We are the latter, and there are different degrees of affiliation that can be worked out. So examples of this, Children's Hospital of Philadelphia is actually an affiliation with the department. It's not fully integrated. It's close, but not quite. Washington University, the same. UAB, the same. And then we are in that model as well. So we have an affiliation agreement that is tighter, and we're working together to see where we're going over time to maybe increase that. So this is, as you know, in January, the Pediatric Academic Medical Center Committee, which is leaderships of Norton Healthcare, Children's Hospital, and School of Medicine, began to meet together monthly. And it's been a great year, I would say. And I think we've actually all looked forward to those meetings. And so we're increasingly looking for ways to collaborate. So I see this as a great success story. And we're really just at the beginning. Now, in terms of our departmental finances, I'll just tell you we are on budget for the year. That is good. We did budget a deficit. It is smaller than it was before. And we have a number of things that we're initiating to continue to work on that. Some of them are under our control, some are not, but there are things that we will increasingly be discussing at the division levels about what are the things that are under our direct control that we can help with in terms of patient access at times. And then, of course, one of the answers ongoing in the future for all academic medical centers, actually probably all of healthcare, even not just academic, is going to be philanthropy. Things to work on, again, allude to access, patient experience. We need to decrease some wait times decrease the times to the appointment, decrease some of the times at the appointment. We need to have more multidisciplinary options where patients can see more of us on the same day. We need better facilities. Stay tuned. And we have to have outstanding communication with our referring providers. So I think we already have a really good service mentality, but we probably need to keep that at the forefront and push it further. Now this slide I've entitled Economics versus Accounting because sometimes you have to spend money in ways to make money in the end. And if you look at the green domino at the end, maximum value reimbursement and retention of patient referral base, that's what we have to be in the future together. To get there, we need excellent physicians and other healthcare providers. We need outstanding nurses and hospital staff. We have to recruit and retain. And then when you're running a residency program, we have to recruit outstanding residents. And I would say we've been doing that, guys. But it takes all of these things together to build and sustain a culture of excellence and patient safety and improvement that lets you provide that efficient care with excellent outcomes and high patient satisfaction. So all of these things go together. So as a pediatric workforce, we are a key part of that. And the vast majority of pediatric medical subspecialists and many pediatric surgeons are employed for life in academic medical centers. There's not a big cadre of them out in private practice. There's a couple of exceptions, but not many. This is a workforce that is not easily recruited or easily retained because there are options for many people. We compete with the major regional and national children's hospitals and medical schools. So what we have available to someone and our reputation matters in our recruiting. An academic work component is desired by many of the people that we would like to come here. And a strong residency program is essential. So just to say that's who we are. We do matter because if we're not here, the care for the children is not here. It will have to be somewhere else. So we'll be paying this a lot of attention. And just to remind you, some of you, I know none of you are burned out ever, right? No, it doesn't apply to us. No, it probably does to many of us at different times. Some of it's EHR related, some of it's just related to just increasing demands in all aspects of care in our lives. We will be trying to pay more attention to this, both at the school and the departmental level. Now, this is a slide near Chapel Hill, North Carolina, taken by a friend I have. And so if you notice, you can go in one direction. It's south, west, and east, which means it's just not north. And he sent this out, and I just thought it was great. So the message here, the road may be difficult, but it is passable. We can get there. Okay. Some opportunities. Another vignette. A 5-year-old cousin, former preemie, lots of neonatal problems. You see another list of specialists that might be engaged with a child like this. And many of you have seen children just like this. You see what it takes to care for so many of these complex children. So I show this as an opportunity, a learning healthcare system. Basically, this is also where we have to go, and it's both a challenge and an opportunity. But we need to get to the point where we have data sharing, data collection together that allows us to do analytics to provide high-quality care, to know what a patient is missing. We can know that they haven't had, on the adult side, a colonoscopy, or maybe they're missing a vaccine as a child, or that there's not been some service that that child with a particular diagnosis needs to have by a certain specialist because it's not showing up in the system. So an alert can be had that alerts either a case manager, nurse navigator, someone that we need to track that child down and get them in for that care. So that's how you accomplish population health as opposed to fee-for-service. So you're engaged, you're doing analytics, you're finding people, you're helping them, and not simply relying on them to show up on their own. Key activities, again, intelligent automation. I put something here called Watson, which is a computer. You've seen the commercials for it. There are medical applications, again, of pattern recognition, analytics, and giving you these types of alerts that you can build in. It's pretty sophisticated computer programming and built off local databases. Other activities, comparative effectiveness research, which you do with big databases. Positive deviance, which when I first read this, I'm like, what is that? But it's looking at high-performing teams and saying, what are they doing, and can we replicate that? Surveillance, again, means gather everything you can. Predictive modeling goes back to Watson. Again, this patient, have they shown up for this right care, or they need this based on their diagnosis list, and we're not seeing it. And then clinical decision support, when a patient shows up in front of you, based on their patterns of visits and diagnosis before that, you can get prompts that let you know this would be a good thing for you to review with this patient, either as a preventative measure or potentially a diagnostic test. Metrics. So many of you will consider this a challenge and not an opportunity, but I'm calling it an opportunity because we need to be out in front of it. It is really already on our adult world. It is coming close to us, but we're increasingly going to have measures of quality that are going to be against which we will be assessed and for which our reimbursement will be aligned. So this is not something to say, well, I'll wait until it happens. We need to learn about it. We need to think about what matters now. We need to be part of the teams in our national organizations that are working with these metrics. AAP is working on this. Peds ID Societies has a group started on this. Many of the others may as well. So get involved. Be ahead of this curve. You go to the AAP website, they have a lot of guidance even about how to think about some of these things. What we're after is relevant and actionable types of measures. There will be measures made that make no sense or don't move the needle, and we need to actually be able to fight those, but provide ones that are appropriate in their place. And these are some, there's a 2017 core set for children's healthcare quality. This is part of the CHIP program and Medicaid. These are actually already out. They've not necessarily been rolled out to us, but they are coming. This is just a partial list. And another thing, just in terms of national organizations and opportunities to get involved both in advocacy and also in terms of making a difference in the way information flows. I have the privilege of being on this particular task force. We met last week in Chicago and trying to look at AAP policy where we have guidelines, clinical statements, policy statements, and help practitioners know what to make of it. Do I really need to follow that? What's the level of evidence? And then in our sort of real-time world, do we give them a bunch of pros or do we give you bullet points? So we developed an architecture as a group that may look something like, we'll give you some bullet points. It will be obviously online in some fashion with links to a summary that will give you some level of why this is the recommendation. There'll be evidence grades with it, and then the further links to original data sources. There'll be toolkits for implementing recommendations and how to measure them from a QI perspective. And then to make this work, there's got to be ongoing curation of evidence. So you have to have groups of people, i.e. many of you, if you're engaged with your sections in the AP, who take part with methodologists and research librarians in keeping up with the content and vetting the content for what might need to change. This is going to be ongoing work. So this is a starting point, but something to keep going. Okay. We need better outpatient facilities for all of these reasons. And guess what? Thunder over Louisville. So I think we showed this last year of where the new pediatric medical office is going to be. Here's the stacking diagram, which I won't go through in great detail, but it's going to be 7 floors of patient areas and an 8th floor partial conference center. About 170,000 square feet, plus or minus a little bit, and almost $80 million. The typical floor layout, they'll all be a little bit different, but will look something like this with patient rooms along the outside, and some inner areas with different charting regions. We're working on how you will fit into this building, so when you hear conversations about neighborhood, this is not a trivial task. We've got now 16 months. We should be in this. We're on schedule for July 1 of 18. Just to remind you, some of the mock-ups of what it's going to look like. First floor lobby, patient entry areas into the clinic spaces, patient rooms. They're starting the 3rd floor. You can get a sense of how the scope of it is. This was Wednesday morning from other views. That's the lower level, the interior. There's a mock-up exam room in Kornhauser, so you can get a sense of what this actually may look like. Here's an external view from Chestnut with the bridge that'll cross over from the parking deck. And a view from Preston. The dental school would be kind of right beside this. But that's not all. Norton Children's is planning renovations. Leadership is taking plans to their board of directors, new cardiac ICU, new medical surgical units, conference centers. Pending approval, we'll have substantial physical plant upgrade in the hospital over the next couple of years as well. By the way, the hospital just had its 125th anniversary. That's a pretty incredible milestone. And the hospital has been grateful, or I'm grateful that they've shared this picture. This is what the conference center will look like. That's the exterior when this is done, if things go according to plan. So a fact we may often forget, between the Department of Pediatrics and all of our colleagues in other departments who are focused on pediatric care, and Norton Children's Hospital and Norton Healthcare and their employed physicians, together we comprise one of the larger children's medical centers in the United States. We are not small. The average faculty size of departments of pediatrics in this country is less than 100. So we're not trivial, and we're increasingly recognized on the national landscape together. Now, quick excursion into these areas. So again, the last divisions. We can get you all involved here. Again, this is a patient. This is not an unusual patient scenario who would need this type of care. All right, teaching I'm not going to spend much time on, mainly because it is such a strength. We have excellent leadership. I can see sitting right here on the front row. We have faculty involved in key roles in basic sciences. Our clerkship is ranked amongst the top in the School of Medicine. We have a lot of graduating medical students going into pediatrics. The residency program is flourishing. We've had excellent recruitment. This past year we had a 100% board pass rate. We have 8 fellowship programs now with one more expected. Many of you are engaged in national CME events as teachers. So this is really a place where I think we excel. Research. I like this cover of pediatric research because it shows how research is ultimately done. We all stand on each other's shoulders. With few exceptions, no one researcher makes the discovery that changes everything about a way a disease is treated. We do studies that make slight changes, maybe refute something, but we all are part of a bigger whole. We're always uncovering a new detail. But this is important work that we do. We actually have research units that are active in all of the areas. We have basic and applied sciences, clinical trials, outcomes research, and there's different ways we might use the term translational research, but there's multiple components of that, so we can be engaged in all of that. We also do education research. I would say is an important fourth domain. And I put the U of L Autism Center in there just to not forget about it because it can actually touch all of these areas. Basic science team, great successes. 36 publications in 2016, multiple grants, including one from the American Diabetes Association, participation on numerous editorial boards, collaborations with 3 universities in China, many trainees from there with much success when they go home. This is one of the hospitals in China, the Bethune. I think it's the first Bethune hospital. Many of their hospitals are bigger than anything we even think about. The Kosair Charities Pediatric Clinical Research Unit, big news, awarded one of the Idea States grants to provide some NIH trials infrastructure, with Jan Sullivan and Sarah Watson leading that, but many others involved. This continues the growing reputation of excellence in clinical trials that we have together with U of L Pediatrics and Norton Healthcare, Norton Children's, as a go-to site. We are increasingly asked to be parts of national research networks in many of our specialties. Currently, there are 65 active industry-sponsored trials, 37 foundation grant consortium trials, 12 of which are NIH-funded, and 9 local investigator-initiated trials in the Pediatric Clinical Trials Unit that works closely with KCPCRU, based out of the Infectious Diseases Division with Gary Marshall. It continues its historic focus on vaccine and antimicrobial trials, currently 16 trials, 4 NIH-funded, 8 publications in 2016 just on the clinical trials with others in other areas. Outcomes research. Our CARDS unit, now led by Michael Smith, has ongoing collaboration with Kentucky Medicaid on data analysis. We're looking now at still the work on psychotropic overprescribing, adding antimicrobial overprescribing and emergency department utilization and looking to increase that further. Gil Liu, who's been part of this, is now the Kentucky Medicaid medical director, and it remains a key part of that effort. Just found out the group had 9 abstracts with 4 platforms accepted to PAS in May. Had 21 publications from this work, various parts of this group in 2016. Just some examples. First, with basic science, on the left is myocardial regeneration potential of three-dimensional engineered cardiac tissues that involve human-induced pluripotent stem cells. This is from Brad's lab and his team. Very nice demonstration of concept of how you can grow and produce layers, multi-complex layered tissues that might eventually make its way into patient care in terms of heart defects. Our other basic scientists, and I won't name you all, but Lou and Yi and others of you involved in this paper, published in Diabetes, again looking at means of reducing diabetic cardiomyopathy. Mike Smith is part of the work with the antimicrobial clinical trials, lead author on a study on looking at clindamycin in obese patients done with the Pediatric Trials Network that's based out of Duke. So we have an increasingly strong relationship with that group. Powell Brothers are listing performances on secondary findings, preferences, the preferences instrument for genomic secondary results. So you send someone for genetic testing for one reason, and you do whole genome sequencing, and you find other things you weren't looking for. How do you deal with that? What are the ethics around that? So Kyle has research in that area. Education research. Aaron Calhoun and many of you involved with this when the mannequin dies. So stimulation. How do we teach people how to handle situations? Oops. And then example of outcomes research, policy-related research. John Myers and colleagues in School of Nursing, effective fireworks laws on pediatric fireworks-related burn injuries, just showing that as fireworks laws have relaxed, injuries have gone up. So ways that we are contributing. And some pictures. This is a visiting group from, is it Wenzhou? Okay. You can say it better. Team coming to visit with us, with whom our group collaborates. Back in November, with Lou Kai presenting. CARDS unit field trip to Frankfurt to meet with state people. We were happy when we left. One quick thing to just tell you about a therapy, a class of therapy that may be coming our way. This is not done here, but nationally. MicroRNAs have been discussed for a number of years, antisense, as ways to either promote or turn off genetic signaling, gene transcription, translation. Spinal muscular atrophy with death of motor neurons because you don't make a certain protein has been the most common genetic-related childhood death. And this therapy actually takes an approach that allows functional protein to be produced so that the motor neurons survive and may end up curing this or at least providing a much higher quality of life and a much longer life. So things like that are coming. And just to remind you, keep reading. And we hope we have more cold weather so there are fewer mosquitoes in the summer. This mosquito carries Zika, dengue, chikungunya. We don't have a lot of it up here, but the warmer the winter, the better the odds. All right, leadership bandwidth. And I put here, there are a lot of other health professionals besides physicians and nurse practitioners who help us take care of children. And there are a lot of nurses and other hospital staff, and I'm sure I've left categories off. But our work in the health of children requires all of them together. So every effort is important. Okay, a little word game. So as we go forward from a leadership standpoint, we will continue to work to have an environment that promotes or balances these words with our goal that we have a workforce that fills these words. So we'll keep at it. I know that isn't always there every day, but it is our goal. There's some other questions that we might ask. And I would tell you every single one of these questions is valid and important. Every one of them. And some of them may be more important to one of us than another, but they are all important questions. Look at that list. Sometimes those questions may collide with one another. So I just put this up as the lens for us to try to get to look at those situations. I think hopefully we'll have fewer of them as we go forward. But again, those are all important questions. And sometimes priorities have to compete. But this is the way we hopefully can resolve things as we work together. Now lastly, this work of managing all of this is pretty big, and one or two people can't do it. So Kim Boland, who has been Vice Chair for Education, is now going to be Executive Vice Chair. So she's going to continue her roles in education and add a few more things, some faculty affairs and things like that, and work with strategic planning. Actually, all of this group will work with strategic planning, but Kim will take a lead role in that. Jeff Grill, I'm taking away the associate category, and he'll play an increasing role as vice chair for community relations and outreach. Faye Jones is going to be vice chair for inclusive excellence to help us as we think about recruiting and retaining diverse faculty, diverse trainees, and part of I've asked her to tell me if she ever sees evidence of implicit bias in myself or our leadership so that we can work on those things. Sometimes we don't realize. And so Faye will be helping us with those aspects again, as well as strategy. And In Kim will be vice chair for clinical operations, again, taking over some of the work I've been working on and hopefully extending it, improving upon it as we launch toward the new building and other things over time. And then our bench, of course, with Brad as vice chair for research. It's a deeper bench that we have now, lots of talent. We need all of it. Again, but we're not alone. There are many of you in important other leadership roles and divisions, the hospital, our central administrative staff, and others of you with various roles. We succeed together, not alone. I'm going to close with this, which I guess a couple of years ago, I think Ron Morton acquainted us with this quote from a person named Neil Postman. He wrote a book called The Disappearance of Childhood in 1982, and one of the key messages was children are things he said, children are the living messages we send to a time we will not see. So to tie back to our mission, and we need to send them forward with as few aces as possible. And that is really our challenge. There's plenty of work to be done. Another interesting thing he put here is it's quite possible for a culture to exist without a social idea of children. This is a relatively modern construct, and one I think we need to continue to grow. And we can contribute in many ways, not just through direct health care, but through advocacy. I'm going to close. This is last Friday night, looking out the chairman's office at what was a peaceful sunset. So I'll stop there and entertain a few questions.
Well, Charles, that was terrific. It's always nice to see when we have continuity of excellence, and I too want to recognize Jerry for his years of service, and he has been an incredible leader, and I would say he's been a mentor as well. And so we have, it's just been terrific to work with you, and I feel very confident in continuity of leadership of the department. And I'm excited about your interim role and look forward to working with you. And I hope that you realize how blessed you are to have the leadership and the continuity that you have. So thank you.
Thank you, Tony.
Kudos to PEDS.
And
I just wanted to thank Jerry first for all that you've done for the department, certainly for forensics. I suspect we could probably pass the microphone for the next couple of hours if we had the time. But Charles, I also wanted to congratulate and thank you. I think in particular, I'm excited about the new vice chair for inclusiveness. I think your message of adding the importance of diversity into our overall mission and hearing that come from you is incredibly important for our department and for the school as a whole. So I just wanted to thank you for that.
thank you. So one thing I just would say, as I've been here now 10 and a half years, to have the privilege of working under Jerry, with Jerry, and what leadership that is dedicated to serving everyone else and not himself. How rare that is and how important that is, and that I will try to continue that. But all I can say is I think an ovation is warranted. So Jerry, thank you. And just so you know, he's actually not going away. He is going to be chair emeritus. He's still going to be engaged. I will still be seeking his counsel. So he's not really gone, just so you know. So, but thank you. And thank you all. So go back to work.